Good morning, good evening, ladies and gentlemen. My presentation today is going to be addressing emergency obstetric care in the era of COVID pandemic. I'll go through this outline. We'll just remind ourselves on emergency obstetric care. I'll be sharing a data from Aminu Kano Teaching Hospital, Nigeria. Then we'll look at association between COVID infection and severe preeclampsia, eclampsia. And then we'll discuss a little about building a resilient health system for emergency obstetric care, and then we will conclude. We all know that all socioeconomic programs, while good for maternal well-being, cannot prevent direct medical complications in pregnancy. And therefore, we must have strategies in place to treat these conditions whenever and wherever they occur. And that's actually the concept of emergency obstetric care. Maternal death will continue to occur unless we have strategies in place whereby when a mother in labor can have access, where a mother in labor can have access to a well-equipped and competent facility, especially when she develops a complication. By definition, emergency obstetric care are actually life-saving procedures in emergencies that save women with complications when they come in labor or during delivery. And we know that most of these complications will either be pregnancy-induced hypertension, severe preeclampsia, eclampsia, PPH, postpartum hemorrhage, sepsis, obstructed labor, or abortion. And it is lack of one or more of these life-saving procedures for this condition that actually cause maternal death. And we also remember that there are two types of emergency obstetric care. We have the basic one that have the 7 signal functions, and then we have the comprehensive that has the 7 signal functions plus facilities for blood transfusion and facilities for emergency cesarean section. Now, when we looked at the data in our labor ward in Aminu Kano Teaching Hospital during the peak of the pandemic in Nigeria in 2020, between March and July, we realized that we're having a lot of cases of severe preeclampsia, eclampsia. And then we now said, let us actually document it. And then we looked at the figures between March and July of 2020. And we also looked at the same figures between March and July 2019, 2018, 2017, and 2016. And it was very obvious that, severe preeclampsia and eclampsia were many more, they presented more in 2020 compared to 2016, 2017, 2018, 2019. For example, the dark blue color, if you look at the line graph, the dark blue color is actually, it's 2016, the orange is 2017, the gray is 2018, and then the yellow is 2019, and then the light blue above is 2020. Now in April 2018, we had less than 3-4 cases in April 2018, but we had almost 23 cases in April 2020. And if you look at the blue color, 2016, in May, we had about, let's say 6 cases, while we had almost 18 cases in 2020. So there was an apparent increase of severe preeclampsia and eclampsia during the pandemic. Now, we did a bit of statistics, and if you look at total delivery between March and July 2016, we had 66 eclamptics and severe preeclamptics out of 1,549 deliveries. And then when you look at 2020 March to July, we had 132 patients with preeclampsia, eclampsia out of 1,636. So we had an odds ratio of almost twice as much as that of 2016. So there was an obvious statistical analysis that showed that really there was an increase in eclampsia in this year. So there is an occurrence of preeclampsia-like syndrome in women with COVID infection. And there's a lot in the literature showing that if you actually test the uterine artery pulsatility index on Doppler and do the serum soluble FMS like tyrosine kinase and the placental growth hormone, you find out that in COVID, they are usually normal, whilst in severe preeclampsia, they are actually raised. So this can actually help us differentiate. But of course, in low middle income countries, we really don't have this facilities to do this test. And then it suggested that the widespread inflammation and endothelial damage, which is termed cytokine storm, actually in coronavirus, is actually the one that is related to organ injury instead of defective placental injury that is seen in preeclampsia. Now, what are the reasons why we had increased preeclampsia? The possible reasons. One is there is disrupted essential services. So women were not able to access antenatal care, and therefore those that had blood pressure were not picked up unless they now come with severe preeclampsia, because we noticed that we had almost 75% reduction in our antenatal attenders within these 3 months in 2020. And then of course, lockdown measures would hamper access to health facilities. And then we had shortages of healthcare providers, and therefore hospitals around us weren't providing healthcare, so all of them were coming to Aminu Kano Teaching Hospital. Then of course we had lack of testing, so we didn't know really, is it eclampsia or is it actually COVID cases? Because we couldn't actually test them. At that time, we didn't have testing facilities. And then women didn't want to come to the hospital until they were in emergencies. And that is why we had quite a lot of them. So what do we do in trying to build a resilient healthcare system for emergency obstetric care in low middle income countries? I think it's very important that we ensure the provision of emergency obstetric care. Whatever is happening in a pandemic, we must ensure that we can provide emergency obstetric care in our facilities, which means we should have adequate human resource apart from the 7 or the 9 signal functions of emergency obstetric care. We must have adequate human resource. We must ensure adequate personal protective equipment. We must have clear guidelines and protocols because this took a long time to be present in our environment. Adequate testing facilities within the reach of our women when they come in labor. And then we should have adequate isolation facilities so that if we test you and you become positive, we can take you to an isolation. And then we must have adequate data management for decision making. It's very important to capture every data because that will help us take a decision. In conclusion, there may be associated increase in emergency obstetric care cases, in COVID pandemics. We should still think of that, and we should look and see whether we can really find out, from the various facilities what really happened. And we really need further research to understand the relationship between eclampsia and COVID infection, especially in an environment where we have very high eclamptic rate. I think we should try and see if we can do further research with support from people to really be able to understand the relationship. Then there is a need to strengthen our healthcare system to be resilient and be able to absorb all the effects, of further pandemic. Thank you very much.